Good afternoon, everyone. Good afternoon. We're just going to be a couple more minutes. Apologies for the delayed start. Unfortunately, we've had just some IT issues over the camera. So if we could just give a couple of minutes to settle ourselves, and we'll begin at 5 minutes past. Thank you. Good afternoon, everyone. I'd like to welcome members to this afternoon's in-person meeting of the Rutland Health and Wellbeing Board, and to members of the public who are listening in via the Zoom webcast. I know also we've got a couple of members of our committee who are also zooming in. We have yet another busy agenda for today's meeting. So firstly, to practical matters, we're not expecting a test of the building's fire alarm this afternoon. So if the fire alarm does sound, could attendees please exit the building via the nearest exit, which is here or here. The rallying point is to the rear of the car park. I'd like to remind members of the board to please raise their hand if they wish to speak, and to ensure that their microphone is switched on when addressing an item, for the benefit of the webcast and the recording, and muted when not. I'll, as always, refer to Jane from governance if I need to record a vote or for any procedural matters. I'd also like to extend a welcome to Rutland County Council's new Director of Adult Social Services, Kim Sorsky, who is joining us officially for her first meeting. So welcome to the board, Kim. Right, so moving on to apologies. Jane, do we have any apologies?
Thank you, Chair. We have not received any apologies.
Thank you. The minutes of the meeting. So to confirm the minutes of the meeting on the 24th of January, I'll be happy to propose the minutes. Can I have a seconder, please? Thanks, Deborah. And then all those in favour, please. Thank you. Actions arising. We had 5 actions from the meeting held on the 24th. We'll go through them. So, Catherine, the first was to you, to collate falls data and distribute a briefing to board members for their information.
Thank you. Yeah, I have looked into this. The issue we have is an anomaly with 2 different sets of data. From public health, we have a high level of hip fractures over the period 2019 to 2021, which averaged at 78 per year, which is very, very high compared to what we see in adult social care, particularly the therapy services. For example, through January to December 2022, therapy services were aware of only 8 hip fractures. Just want to highlight that therapy service in Rutland does a lot of falls prevention work. They attend the falls, LLR falls steering group. The falls prevention programme is doing really, really well. They respond very quickly to referrals to try and prevent falls, reduce likelihood of falls. But what I'm able to say is we have now got somebody in public health who is going to look into this anomaly for us. So hopefully we'll finally get some understanding of why the data is so different.
Thank you very much, Catherine. It's possibly worth us not leaving it as an action, but maybe putting it onto the forward plan, just so we can just go back to that. So I think, do we think 6 months, is that possibly enough time for public health to come, for us to have those conversations?
I think we can probably do it before then. I think it's an erroneous data issue that we're just trying to unpick at the moment. So hopefully by June, we may well have the answer.
Okay, fantastic. We'll carry it forward then to the June meeting, and hopefully we can square that all off then. Thank you very much. The second one was for myself to send details of the feedback. Oh, sorry.
It was me, I couldn't find the button. Could I just ask that in those falls data, if possible, we can have in sort of institutional hospitals or care homes falls and domestic falls? Is that possible?
To be absolutely honest, I'm not sure. We'll try. Share as much information, detail as possible.
I think, and I don't know whether Kim can come in, and I'm putting you on the spot now. I have a feeling, and again, we can report this back. I have a feeling with the falls prevention that's been done in care homes. I don't know whether Karen can answer either. I know it's not in her remit, so probably not. I do know that we've had no falls. A report did cross my desk on that. So I think.
Yeah, thank you. We've got some good data and narrative around the falls prevention programme operating through the residential homes. So we have got that. So that's something very clear that I can bring as well. That helps.
Yeah, and we can connect it to safeguarding falls as well, because falls at care homes will be alerts through to the safeguarding team as well. So they will have been investigated and looked at how that prevention works. So there's prevention work that's going in across care homes, but also the social care and health response of those that fall within those care homes. And there are some care homes that may be higher than others. So there'll be quite a lot of work in there involved.
My concern is that I've actually been involved with a very elderly gentleman who has had 2 falls in the previous 2 or 3 months in his own home. The falls, he fell between working hours during the day the first time, and the falls team came within a couple of hours. Absolutely fantastic. I was really impressed. Second time he fell, it was about 10:15 at night. And getting help for him then was a lot more difficult. There was an ambulance called, it was too big for us to lift up off the floor, move off the floor. So I'm concerned that there's a gap. There could be a gap with people falling in their own homes, especially if they fall out of working hour, set working times. I just wanted to flag it up.
Yeah,
Well, thank you. I mean, that's really, I think that's something that across the health and social care, that's something we want to look at, are those gaps. That's something you've highlighted that we are aware of actually, and we want to see how we can better join up our systems and look at those particular gaps that you've identified.
thanks, Janet. The second action was for myself to send details of our feedback on the ICP strategy, which I did do, so I get a gold star, thank you. The second one was for you, Sarah, to speak to Jane regarding, I think we did do that, it was regarding, it's on the agenda, isn't it? The fourth one, again, it's on the agenda. Our colleagues from NHS England will be are on the agenda for dental services. And then the fifth, I'm afraid it's back to you, Catherine, the professional stake to update us with the details of professional stakeholders to be consulted with regard to the communication and engagement plan to ensure all professional stakeholders were included.
Yes, so thank you. We have managed to kind of get the plan finalised. All the stakeholders have been consulted and fed back. The one thing that we're going to do in addition is a 2-page summary at the end of the plan, just to make it more easy read and more accessible for members of the public. So that will be done in time for the June Health and Wellbeing Board. But the actual content was all agreed. And what I will do, I will email around that list of stakeholders.
Thanks very much. So that was the last of our actions. So next we'll go to declarations of interest. Do we have any interest to be declared this afternoon? No, thank you. So now on to petitions, deputations and questions. Jane, have we received any?
Yes, Chair, we have received 2 questions with short notice, one from Mr. Andrew Robinson and one from Mr. Ramsey Ross. As per Procedure Rule 73 of the Constitution, the time allowed for any questions submitted under this procedure shall be a maximum of 15 minutes, provided that it falls within the total time of 30 minutes allowed for petitions, deputations and questions. A maximum of 1 minute shall be allowed to ask each question, and no supplementary question will be allowed. The maximum time for answering a question shall be 2 minutes. Every question should be put and answered without discussion. The name of the person who asked the question, a summary of the question and the response shall be recorded in the minutes. I shall now ask Mr. Robinson to approach the table and read out his question.
Good afternoon, Mr. Robinson.
Good afternoon, all of you. I'd like to ask the following question. Will the ICB forward plan for Rutland include an implementation plan and timeline so that the public can understand when each of the 7 strategic actions will actually be delivered?
Thank you, Mr. Robinson. Do we have, I think Sarah Primi, you're going to do a brief answer.
Thank you for that question. So the first thing I would say is that the 5-year forward plan is an LLR plan. It's a Leicester, Leicestershire and Rutland plan. The guidance is clear that it should be a delivery plan. So there will be delivery actions within the 5-year forward view that set out how we're going to deliver the priorities that we've identified in there. At this moment in time, it might be an annex to the plan or it might be a separate document, but the two things will work together. Because I don't want to, I want the plan to be quite short so that it's readable and understandable, and then the delivery actions will be either in an appendix or a separate document.
Thank you.
That's the plan at the moment anyway.
Thank you.
Thank you. We will give a written response.
Thank you very much.
Thank you, Mr. Robinson. I will now ask Mr. Ramsey to approach the table and read his question.
Thank you. Can Health and Wellbeing advise whether it considers the present state of completion of the Joint Health and Wellbeing Strategy (brackets Health Plan for Rutland) to be such as to be sufficient to, 1, be incorporated by LLR ICB in its 5-year forward plan (brackets strategic plan) on the 8th of June, and 2, be the basis of broad public consultation in Rutland prior to the ICB's submission of any 5-year forward plan (brackets strategic plan) to the Department of Health on the 29th of June 2023. And 3, can the details of the supporting plan for such future work streams between Rutland Health and Wellbeing and the ICB in the quarter to 30th June 2023 be made public? Thank you.
Thank you, Mr. Ramsey. Sarah, do we have?
Yeah, I'll start. I don't know whether from a health and wellbeing strategy anybody wants to answer it, but from a 5-year forward plan perspective, the first thing I would say is that, well, I'll start off by saying that the Health and Wellbeing Board has developed its health and wellbeing strategy, which was based on evidence and what people had told us as a board. And we did quite a lot of engagement around that plan. And as a board, we've signed that strategy off, haven't we? As such, I don't expect the 5-year forward view to be a duplication of that. It needs to align to the health and wellbeing strategy that is for Rutland, and you need to assure yourself in the process as set out in the guidance that it is aligned in it and it has been taken into account, but it won't be a complete duplication of it, because that would undermine the place-based plan to start off with, and to be honest, a duplication of work. So there will be a period of engagement post the pre-election period. So it will come back. So I've got an introduction to the 5-year plan on the agenda for today, but the completed draft plan will come back to you for consideration in due course, possibly in your May-June meeting, depending on where it sits in the timetable. So that was all I was going to say, I think, in relation to those two things. So yeah, there will be a period of engagement post the pre-election period. And although the 5-year forward view plan will take account of and align itself, it's not a duplication as such of the health and wellbeing strategy, and the delivery plan that sits behind that is owned by this group, isn't it?
Thank you. Did anyone else? Mike?
Yeah, thanks, Chair. And I think just to pick up on the JSNA point, two ways of answering this, one of which is, yes, the JSNA does inform the 5-year forward view, as Sarah says. As we've always said, the JSNA isn't a one-off document, it is a bit rolling. So I guess I would say the forward plan is informed by the JSNA chapters as they stand, but as always, as Sarah says, it becomes something of a rolling process, and any further chapters would be updated in the delivery plan.
Yeah, there is a requirement.
Yeah.
There is a requirement as well to keep the joint forward plan up to date on an annual basis.
Thank you. Mr. Ramsey, I'm aware we probably didn't answer possibly all three of your parts of your question. We will, a written response, I'll ensure that all parts are answered in the written response, which we will send to you, which we will also append to the minutes. Thank you very much indeed. Item 6 is questions with notice from members. Chair, do we have any questions with notice?
None received, Chair.
Thank you. Item 7 is notices with motion from members.
None received, Chair.
Thank you. And we now move on to item number 8, which is access to NHS dental services in Rutland for an update. We have a presentation and an update from our colleagues at NHS England regarding access to NHS dental services. So, Chair, Jane, can we
Thank you. Yeah,
through?
I've just promoted Claire Haynes.
I know my real place.
Good afternoon, Claire. Can you hear us? You're on mute. Claire, we can't hear you. No, we can't hear you, I'm afraid.
Bear with us just for a second. Dawn, can we just check the microphone via Zoom? Could you come off mute and just speak for us?
Hi, everyone.
Oh, okay. Thank you, Dawn.
No.
It seems to be a problem with you, Claire, I'm afraid.
Are there any of your colleagues that I can promote through into the meeting, Claire?
She's typing into chat.
Oh, yeah, she was typing into chat.
Carol
Picture. Modern technology, love it.
That's good.
Hi, Carol, can you hear me?
Hello, can you hear me?
Yes, we can hear you, Carol. We can't see you. Your camera is not on.
Oh, I've got my camera on. I'm not quite sure why it's not. I'll try and go in the settings. Oh, gosh. Is that better?
There we go. That's nice.
Oh.
That's better. Carol.
Sorry, there is a number of other colleagues with me, but I think we've been having some technical difficulties joining the meeting today. So I think there are other colleagues on as well that we may need to come to when we get to the questioning element after the presentation.
That's okay. Well, if you'd like to give me their names now, I can pull them through into the meeting.
Oh, okay. So I think you've already got Claire Hames. There is Stephen Claydon or Steve Claydon. Adam Morby and Rizwana Lala. Oh, I can see Steve now.
That should be everybody pulled through.
Yes, thank you.
Right, I will now bring up your presentation.
Thank you. So would you like me to just talk through the presentation?
That would be fantastic. Thank you, Carol.
Okay, will do.
You should be able to see it on your screens now.
Yes, I can. Thank you. Yes. So we understand that I think the colleagues attended a previous meeting last year where a paper was presented and a slide presentation as well. So we've just as a team, we've tried to obviously update the current position with regard to the dental services in the Rutland area. So the first slide is just a map of the areas that we cover within the team. So if you go to the next slide, please. Thank you. So this one just again just sets out where we've currently got the location of NHS dental services. So we have 6 general dental practices within the Rutland area. They're, you know, what we call our high street dental practices. One of those provides extended out of hours and unplanned urgent care. And that practice is open 8 a.m. to 8 p.m. 365 days of the year and is situated in Oakham. In terms of the community dental services, we don't actually have any clinics cited within Rutland. The service is commissioned for Leicestershire. So I believe the nearest clinic to Rutland would possibly be the Melton Mowbray clinic that we have for community dental services. In terms of secondary care and hospital services, the more complex treatment and those patients needing general anaesthetic, again, that's commissioned with University Hospitals of Leicester NHS Trust. And again, those hospital clinics are located within Leicester City and Glenfield. And then we have our specialist services, which is orthodontic services. We have the one practice in Uppingham and one in Oakham as well. And then we have our intermediate minor oral surgery service, which again is for more complex extractions that don't require hospital care, but are more specialist than our general dental service practices can complete. So again, we have one of those services, but again, that's within Leicestershire rather than located in Rutland. So the next slide, please. Again, this is just setting out some of the challenges that we have from sort of our national and local level. I mean, obviously, from the last paper, you'll know that the challenges that have existed, that we've had some prior to the pandemic, and obviously the pandemic exacerbated those challenges that existed. The access issues, again, is something that's across the country nationally, and obviously the situation with the current contractual arrangements that we have for dentistry. Within Rutland, again, the situation is probably not a lot different to how it's falling out across the national picture in terms of access to services. Vulnerable groups has been highlighted to us. Unfortunately, we did get a contract hand back in Oakham, but hopefully there is a further slide later on to go through that in terms of what the plans are with the recommissioning. And then during this year, we do have the contract position, and we do have some contracts that are delivering within the Rutland area, but there are a couple as well that where we have concerns of low delivery, and most of the feedback that we're receiving regarding the delivery issues is workforce related. There was a next slide. In terms of these graphs and these the units of dental activity that we commission and the trends, we do only receive this information. Currently, it's been reformatted into our integrated care board footprints. So we only have that for Leicester, Leicestershire and Rutland. I think when we came to look to develop this presentation, I think we did consider whether with Rutland going forward and further work we need to look at within the ICB work next year, that we need to try and see whether we're able to analyse this further to give you a picture for the Rutland area rather than it being for the LLR. But at the moment, the details and the data that we get that's produced that we've reflected here is on the LLR ICB footprint, which the graphs are very similar. You've got the Midlands picture and the Leicester, Leicestershire and Rutland picture, and as you can see, they very much look very similar in terms of where there was the increases and then the dips during the pandemic, and the recovery position for the LLR system area is really good in terms of restoring to around about 96% of pre-pandemic levels. As the slide says, recruitment still is one of the things, as I mentioned, workforce that has the biggest impact on our service delivery. And obviously we are looking at that aspects of care for those higher needs patients that we're looking at when we're developing new initiatives now as well. Next slide, please. So this just gives you, again, we've tried to, with this one, because we can, with some of the software that we have available, look at access and break that down to further areas within ICBs. So this is a picture for Rutland in terms of the dental access position at a point in time. So overall, I think Rutland was slightly lower than the national average. So that was 22.78%, but Rutland was 22.06 during that period. And that is the latest period at the moment that we have for dental access for this level of information. And then we've just tried to break that down in terms of children and adults, because I think children was one of the issues that was raised last time, and access for children. As you can see for Rutland, actually the child access rates for the 0 to 17-year-olds was better than the national rate. So for Rutland, we had 42.49% against the national rate of 33.62% for the same period. But for adults, that was slightly lower than the national rate. The next slide. So in terms of contract terminations, you may be aware that we have had one contract handed back and a termination in the Oakham area. We just wanted to assure the committee that dental activity will not be lost, and we have already looked at interim ways of trying to secure that access whilst we look at a longer term solution. So we are working at the moment with our public health colleagues to look at some of the data that we've just shared with you, and a more recent picture, so we can bring all of that together to look at how we review that and recommission that dental activity. As I said, we've tried to, on an interim basis, do an expression of interest process with practices. Unfortunately, we didn't get the level of interest from practices within the Rutland area, so we did extend the geographical radius was up to 15 miles. So some of that activity has been awarded on an interim basis, but that is within Leicestershire rather than within the Rutland practices currently. Next slide. So this is, again, unfortunately at a LLR system level in terms of the initiatives, which we thought was beneficial to present some of the initiatives that have happened, and where we've deployed those within the Leicestershire and Rutland area, because hopefully some of the patients and public within Rutland maybe still be able to access some of these initiatives, like the weekend scheme, because if they are in Leicestershire practices that are within a travelling distance for Rutland patients, they would be able to still be able to access these schemes as well. So that was the one around the weekend access. We also have done for specialist services additional orthodontic case starts. So I think the next slide has got further initiatives on it. So again, this is another one we're doing with our community dental services to support some of those patients, and it's especially children to be seen in the high street dental practices rather than within the community clinics. Next slide, please. And then these are, again, waiting list initiatives that we've done for some of our specialist services. Again, that as we said, there's a separate one for our community dental services as well for their waiting lists, and with our intermediate minor oral surgery. Say for Rutland, some of these specialist services aren't located within Rutland, so the initiatives themselves are not being delivered in the Rutland area, but within Leicestershire. So, we would hope that patients will still be able to access those, but unfortunately we haven't got any take up of these initiatives within the practices within the Rutland area. And I think just moving forwards, as we work now on a ICB footprint, we'll be obviously looking at that in some more detail to see how we can look at different strategies for those areas and get that feedback as well from dental practices to understand why they weren't able to, look at expressing an interest in some of these initiatives that we've shared with you today. Next slide. This is really just to sum up in terms of where we are currently, in terms of, obviously we do have the Leicestershire and Rutland Oral Health Steering Group, so the work is ongoing and looking at local oral health needs and prevention programmes. And as well, the NHS England has been working with local authorities and the local oral health steering groups and supported that with some funding for some of the initiatives around prevention, as well as we've looked at initiatives to deal with access. Obviously, in terms of integrated care systems, this is one of the services that will be delegated to the LLR ICB from the 1st of April. As a team, we will be being hosted by one of the ICBs within the East Midlands, and that's Nottingham and Nottinghamshire. But the team will continue to provide support and deliver the services that we do now to our 5 ICBs within the East Midlands. The communications team, again, I think there was some stakeholder briefings and updates in terms of resources and posters. Hopefully they have been shared with yourselves previously. And also we do continue to still work with our Health Watch colleagues as one of our main stakeholders moving forwards. We have one of the consultants in dental public health, Rizwana, she's on the call with us today, and we again work with them in terms of looking at that oral health need reducing health inequalities and looking at if we are commissioning or recommissioning, where is that best place across our system areas. The LLR Local Dental Network Chair, that is Steve Claydon, who is also on the call with us today. And he works across that system area with colleagues in the ICB as well, and clinicians to take forward in the future what, you know, the initiatives that are developed, and like I say, working with clinicians to understand and get that feedback with us, and work with commissioners so we can inform those future initiatives at a local level. And then finally, it's just we have the primary care, getting it right first time, that is starting to look at best practices across the areas that we, you know, within the East Midlands that we work with, and trying to look at where there is that variation and how we can reduce some of that variation in the services that we have and delivery. I think, is that the last slide, I think?
Yes, it is. I
Yes,
think.
it is. Thank you.
So yes, so myself and colleagues, you know, we're happy to answer if there are questions from members today.
I'm sure there will be. Just to clarify something, you've never actually presented to this board before. You were actually presented to our scrutiny, under their scrutiny functions. Under local government, scrutiny has a completely different kind of thing they do than we do as the Health and Wellbeing Board. We are the place-based board, as opposed to scrutiny, who are there to scrutinise health functions under their powers driven by the Local Government Act. So I just wanted to clarify.
Oh, thank you. Apologies for
the Health and Wellbeing Board. I'll open it up to colleagues. I'm sure there is some questions. I've got quite a few from the presentation, but I will see if they're answered by my colleagues. I will possibly, I don't know whether Public Health want to come in first. I know Janet from Health Watch does. So we'll introduce Janet Underwood from our Health Watch. Thank you.
Thank you. Thank you for the presentation. I do have quite a few comments and questions. First of all, my understanding was that dentists have been requested to actually put on their websites whether they're taking on NHS patients and whether they have capacity to. Before this presentation yesterday, I looked on all the local dental healthcares on the NHS website, and not one is taking on NHS patients. The 3 messages that were with each dentist within sort of 15-20 mile radius said, we're not taking on new patients, or no update has been provided, or we're taking on new patients only if referred by another dentist. So that is very alarming, that nobody in Rutland and going across the county borders can actually access an NHS dentist, no adult. My next comment is on the slide with the statistics. You said that that's 17, I think it was 17 point something% of adult patients are actually getting, Rutland residents are actually getting NHS dental care. That leaves 82.49% of Rutland adults who are not accessing NHS dental care. That's, I would suspect, primarily because it's not available. But that brings into question what happens to those people who are entitled to free dental care, such as pregnant women, women with babies under a year old, people on benefits, etc. And they can't, people on benefits particularly cannot afford private healthcare. So this is a gross inequality as far as I can understand it. For the weekend access, I note that you've actually facilitated 274 extra units of activity across LLR, 274 units of activity across the whole year for 1.1 million people does not actually seem to me adequate. And then finally, I see that you're mentioning you want to ensure optimum provision of care for patients. And you're going to carry out the LLR oral health needs assessment. What I would like to know is there going to be any Rutland representation, Rutland public representation on that oral health needs assessment group, so that they can actually put the case of what's happening here on the ground? Sorry.
No, I don't know whether you want to come in on any of those points at all before I go to the next person, or.
Yeah, I can try and answer some of them, and I don't know whether my colleagues may want to come in as well. I mean, in terms of the first point and about the NHS website, I think that is something that has been covered in the dental contract reform changes that were going to be introduced in July last year. I'm not aware yet that it's gone through that contractual change that will ensure that they do have to do this and update the websites. But I will look into that, because obviously, again, you know, the picture in terms of whether a practice is accepting or not can change on a regular basis. But that's something that we can take back and have a look and see whether they have, you know, recently refreshed that information or not. I mean, unfortunately, it could be correct that they have refreshed it, and at the current time they don't have that capacity to be able to accept patients. But that is something definitely that we'll look at that website and see whether our practices are updating that, you know, in a way that shows the latest position. Because as you say, that doesn't, in terms of practice, patients wanting to access a practice in Rutland, we would then need to understand if people are then contacting say 111, etc., where will they be directed to access care. I mean, hopefully in terms of urgent care, they would still be able to access that in Rutland, because we do have the practice in Oakham that should be able to support with urgent care. But you know, we do need to look at those that want routine care as well. So certainly that bit, we will look into that further. I think in terms of the statistics and the adult access, I mean, that was a snapshot at a point in time, but also I suppose just to note with that one, I suppose in terms of NHS services and access, it would never be provision for 100% of the population to access NHS services. I think there has always been an element, and this is not just local, it's national, that we look to provide services for a proportion of the population. And as well, in terms of commissioning resources, they're not set at 100% for the population either. But you're quite right again. I mean, that is quite a low percentage in terms of adults, and that will be some of the data that we'll be looking at when we do that review of the oral health need for adults and children. The weekend access, the number, it was actually approved sessions, so it was 274 sessions, which is like a morning or an afternoon. So that would, and again, I think it was roughly around about 8 patients per session. Hopefully Claire's nodding that I've got that bit right. So it would be, you know, it's not units of dental activity, so those sessions would have been able to deliver care for you know, a number of patients. If they achieve the, you know, we looked around about 8. In some cases they may have seen more than 8 patients in one of those sessions. And then yeah, we do need to look at, as I think the last point was around the oral health needs assessment and how that's developed, and the work we need to do on that to take that forward. But I think my dental public health colleague Rizwan has got a hand up, so she may be able to add some more information in terms of that oral health need.
Thank you. I'll bring Dr. Sorry, Dr. Lala, do you want to go?
Hi, can you hear me? Sorry, my video is not working, even though I've put it on. Can you hear me though?
Yes, we can hear you. Thank you.
Excellent. So yeah, I just wanted to say in terms of the Carol's already touched on the extended hours. So that's extended hours in addition to what's already commissioned within the GDS service. So it's not just 274 sessions for the whole of the population. There is, the existing GDS dental practices are already there. And you're right in terms of the proportion of the population that are accessing NHS dentistry, it is low. And also in Rutland, it's lower than the national average, which is a concern for us that we are thinking about. But historically, we tend to commission for around about 50% of the population, 50 to 60% of the population, because what we find is that's what we need to get satisfaction at a population level, because a large proportion of the population want to access private dental services, but also just do not want to access dental services because their teeth are fine, or they don't feel the need to, and they would rather access services like the extended hours services, where they're only accessing services if and when they need it, if they're in pain. So that is something that we'll be looking at. In terms of patient voice, we are currently undertaking, and we've already started undertaking, an oral health needs assessment for all of our ICB areas, including Rutland, in terms of where we need to commission activity, additional activity, and any contracts that are handed back, whether they need to be recommissioned within those areas, or looking at areas where there is need and lower levels of activity, because you're right, there is a gross inequality, and we want to make sure that we narrow that inequality. And I've already started having conversations with the various health watch groups, what patients are saying, what feedback they're collating, and certainly the patient and the public voice will be central in the way we commission and design the services. So that is very much on our radar. Going back to the inequalities as well, the NHS Business Services authorities are currently looking at how patients are accessing services and what the inequality is. And what we're finding, looking at the data, is that the lowest 20% of the most deprived populations are accessing services very differently for various reasons. More likely to access urgent services, more likely to have or even have access to routine dental care. And so we'll be looking at that data very, very carefully when we kind of doing our oral health needs assessment. And it very much fits into the NHS England's priority, that we're looking at that kind of core 20% of the population that is really much, very much deprived. In the children and young people strategy, oral health is very much on our radar to kind of reduce that inequality for the most deprived 20% of the population, including children. So yeah, I hope that answers some of your questions, and if you have additional questions, I'm happy to come back with them.
Thank you. I'll bring in Adam Morby, and then I'll just come back on some of your comments, Dr. Lala.
Yeah, I'll try and be very brief because I know other people want to ask questions. Just 2 points to add what my colleagues have actually said. First of all, with regard to the 82% that was mentioned, those patients being mentioned that are on sort of just probably above thresholds for being able to claim some benefits, that they can actually get access to the low income scheme. So that's just something I would like to flag for those types of patients. But accepted, there is the difficulty in still gaining access, even if they can get help towards paying for it. And with regards to the 274 sessions, that wasn't an upper limit that was set by NHS England. That is something that would have been like to be able to access more sessions than that. But unfortunately, that's the number of sessions that the colleagues in dental practice could actually offer across LLR. And if they'd have asked and said they could have offered 374, then the funds would have been found to support that as well. But that was just what was enabled to be offered by the local practices, not a limit that was set by NHS England.
Thank you very much. I will just, I'll let Mike come in just in a second. I just, as chair, I'm slightly concerned. I'm very concerned about dentistry in Rutland. I'm slightly concerned that obviously your team will be working through the ICS and the integrated care system very shortly. Rutland itself in the ICS is a place in its own right, and this presentation today seems to miss that to me. I don't think the team possibly has a good knowledge of Rutland as a place and its own uniqueness. I appreciate Dr. Lala talking about Core 20. However, we know from sitting around this table, it doesn't apply to us. However, we have our own very much deep inequalities down to rurality and things, and the complete lack of dentistry in Rutland when it comes to this subject. I will let colleagues come in, but I think I needed to say that. I also, just one question from me, which we might be able to answer. Under the dental access and the low percentages we're talking about, that was from January to June 22. I just need to confirm that was just before that contract was handed back, wasn't it? So in fact, because those units of work haven't been picked up locally and it's very difficult to access locally, these numbers will actually be a lot more positive than the reality now. And I think that's worth us bearing in mind. I'm not sure if you can confirm when that contract was handed back. I'm pretty sure the letters went out last May from, I don't know whether anyone around the table can remember, but I'm pretty sure it was last May that the contract was handed back. So as chair of the board, I am concerned. I'll let others come in. I think that from a place perspective, it might be very, very worthwhile for colleagues, maybe for us to arrange a meeting outside the board just on dentistry with your team, so that we'll start working together to try. And I appreciate you've got lots of places in your portfolio, but Rutland, although very small, is still a place, and I think it would be very helpful maybe for the team to meet. I think that might be one way ahead. I will now bring in Mike though and see what he has to say.
Yeah, thanks, Jed. To be honest, I was going to make the same point, which is, it feels like both in terms of the opportunities, the slide at the end, and then, as you say, Chair, in terms of a discussion about Core 20+5, it does feel like we're getting an LLR perspective. I'm not really picking up how things will ever change on the ground in Rutland. Further point for me is I think at scrutiny, there was a lot made by yourselves that public health needed to do an oral health needs assessment. We approved that on the last Health and Wellbeing Board, so I'm a little bit concerned that there's still talk about needing to do an oral health needs assessment. So somewhere along the way, it just feels like things aren't quite joined up. And I'll probably look to my colleagues just to make a connection with you guys, just to make certain that you've got the HNA and the rest of it. There's still a point at the end of that, which is actually you can do all the needs assessment and opportunities you like. But I suppose a big question in my mind is, to what extent is this ever going to land in Rutland? In which case, this is a lengthy conversation which won't have a productive output, unfortunately.
I don't know if any of you want to come back on that. Adam.
Yeah, I'll just come back on that. And I totally agree with yourselves. It doesn't appear that we have a Rutland perspective, but I would like to sort of reinforce that colleagues around the table really do understand the issues for LLR, but unfortunately the data is just given in a format that doesn't show that we do have that perspective. I would really welcome as well I think the fact of joining forces, as you say, with yourself, to be able to sort of move forward on different aspects, and it will give us greater clarity than we've got, because there's nobody better than sort of people on the ground that live in a particular area, and that is the main reason for moving towards an integrated care system, that we can actually utilise that knowledge of people sort of in that locality to shape and form the services that they require. But the biggest problem and the biggest issue we have, even if we've got all the other ducks lined up in a row, would be the workforce. And the dental workforce is the real issue that we have. But nationally, they are making pains to try and resolve those issues.
Thank you. I think Dr. Lala, would you like to come in?
Yeah, in terms of the data, so moving forward, I've just had a meeting with the NHS BSA this morning, and we are going to have, moving forward, richer data for Rutland, and looking at what's going to be available. When I talk about core 20, I did mean core 20 for Rutland. So Rutland would be ranked as deprivation within, you know, would also have core 20. So we wouldn't be looking at the LLR footprint without. The data is going to be available moving forward. It hasn't been available historically, but moving forward, it does look like it will be available for Rutland, and we'd be able to see the inequality within Rutland itself. So that is what I meant. I didn't mean on an LLR footprint, so that Rutland would be kind of not regarded. I did meant at Rutland level. So I hope that kind of provides a bit more clarity and reassurance around that.
I'll bring my colleague in, Mitch, actually from Public Health, put him on the spot. But just to clarify, I've sat here and looked at lots of data, and especially around core 20, and I can guarantee Rutland barely sits in any of it. But I don't know whether Mitch or Mike want to come in just to clarify that.
Thank you. Yeah, so just that core 20, like we said already, we won't have any people in Rutland or very minimal. Just from the data point of view, before you start looking into anything from a Rutland specific focus, we have, like we said, got the overall health needs assessment, which is Rutland as a place, but we've also got a health inequalities needs assessment, which looks broader at the health inequalities, which wouldn't show up in the core 20+5. So yeah, we welcome a conversation on that, just to start with that piece of the picture already, because that will probably answer a lot of these questions, and we can work together on those issues around dentistry. So yeah, I think that needs to happen first before you start going into detail.
Thanks, Mitch. I'll just bring in Steve Claydon.
Thank you. Can you hear me?
We can.
Great. Okay. I was just going to go back to a point that Adam Morby made a few minutes ago, and that's about workforce. Workforce is the big limiting factor here, without a shadow of a doubt. Existing contractors within Rutland are struggling to deliver. Despite the fact that services are commissioned, they don't have the workforce to deliver on that. NHS England has preserved or ring-fenced the money that came out of that contract that was handed back, and it will, as I'm sure commissioning colleagues on the call mention, it will be hopefully re-procured. But at the end of the day, if we haven't got someone to deliver the service can't be delivered. It is that simple. At the health and at a committee this morning in Parliament, they said the four main problems for dentistry was workforce, 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 and workforce. It is the big problem. We can do everything we can in terms of commissioning and putting resource there. This is, although resources are very limited within the NHS, resources in terms of money are not the big problem here. It's getting the people in to deliver the service. And I will more than happily work with you and your colleagues to try and see how we can address it, and really how we can attract dentists to come and work within Rutland. But that is the big problem.
Thank you. I think Mike wanted to just come back.
Just to absolutely agree with you, Steve, and I think that's my slight frustration with the comments over the last sort of 50 minutes is, if that's the issue, we just need the issue. There isn't really an awful lot of point doing a lot of detail about core 20+5 and inequalities and access if you just got at the end of it, nothing to deploy but fresh air. And I'd rather the effort went into thinking about how do we actually get more dentists, and how do we get more dentists into Rutland, and then work out where we best deploy them. So I just totally with you on that one.
I think the other point I'd raise is, and I think from a Rutland Place perspective, I think it would be helpful. We're always, it seems to me, when we're kind of within the Leicestershire and Leicester City, because of core 20, we are always left behind because we don't fit into that, and it means Rutland people are left behind. And I think specifically from a Rutland perspective, we know that some of our dentistry statistics are worse than our colleagues in the city and in the Shire. And I think from a Health and Wellbeing Board perspective, it would be great to have the data, to have the kind of background knowledge. I completely agree with you around the workforce, because you're right, it doesn't matter if we can't get the dentists here who will pick up NHS patients, people can't be seen. However, as a Health and Wellbeing Board, we do have some ability to write to the Secretary of State to kind of as ourselves as a place to kind of bring some things to bear. And I think it would be really helpful if we all work together to form a picture to move that forward, so that it's not just yourself saying it or us anecdotally saying it. Actually, we'll have the evidence behind us worked up together. I know certainly Mitch and the JSNA we've done on oral needs is very good. The inequalities work we've done is outstanding, and I think it would be really helpful. I can see Adam probably wants to come back, and I don't know, Stephen, whether yours is the legacy hand or you want to come back as well.
No, I'd
just like to come back. You, Adam. No, I'd just like to come back just to say that, you know, exactly what we want is patients to be seen. We don't want to hear, I mean, there are horrendous stories out there where children can't get access, that adults can't get access, and that is not the situation we want. We really like to work with everybody, and we wouldn't be skewed by data looking at a core 20+5 scenario and take that as the given that that's the level we've got to work to. Ultimately, it's patients that are needing treatment that need to be seen, and that's what we need to be guided by. And I think working together will really dramatically help on that. And secondly, NHS England have recognised really that there are a couple of delays in the system of being able to get workforce actually to be present, to be able to deliver services. And one of those is getting onto the dental performers list. So there are current moves afoot to change how that is actually actioned. But one of the other sort of great delays in the system is the ORE, which is the Overseas Registrants exam, which the General Dental Council has, so that registrants from overseas that could practice in this country, on average at the moment, takes 4.5 years if somebody comes from overseas to actually get to a position where they can deliver NHS services, which is absolutely ludicrous and is not helping anyone. But we're also limited by the number of graduates we have in this country, and trying to increase numbers, even if we would wave a magic wand and increase the number of graduates at university, it would still take 5 years before they actually come out the other end of the system to be able to deliver services as well. But at least NHS England are trying to make inroads to changes to make that whole process quicker. And now we're trying to work with the GDC, General Dental Council, to make sure that they can sort of try and manage that system as best as possible as well.
Sorry, thank you. Do any other colleagues want to come back at all? Janet?
Yeah, I'm speaking from a personal point of view now. My husband and I have not been able to get NHS dental care since pre-COVID. We actually have to go to a private practice in Melton Mowbray. We have to pay so much a month for doing that. The price for doing that has just gone up by 50%. Inflation is 10%. We now can't get an appointment quickly like we used to be able to. So this implies to me that private dentists are now so becoming overwhelmed with people who can't access NHS care, that the problem is extending to private practice as well. So I think I'm flagging up a sort of a note of caution that how long is it going to be before people can't even get into a private dentist either in this area?
Thank you. I think we'll draw this to a close. We've gone way over time on this item, but it's been really interesting. One further point I thought on your slide with regard to secondary care, you name UHL in Leicester. I'm just kind of confirm, are we picking up the patients that are referred to Peterborough City Hospital? because there's also lots of referrals go over to Peterborough for their oral teams. So certainly from the east of the county, but also from some of our Oakham dentists refer straight into Peterborough. So hopefully we need to just pick up that data as well, because otherwise you'll be missing. We know from our urgent care that only about 30% of Rutlanders go look to Leicester for treatment. So it could be that quite a few people are going into secondary care at Peterborough. So that's just one thing for us to add. Now, I think moving forward, and I look to my colleagues in public health, because I think we need to maybe look at getting the JSNAs worked up and everything. I'm wondering if we could do an action for yourselves, our colleagues through dentistry and public health, to come together to with others that you feel appropriate, maybe to look at this from a Rutland Place perspective. I don't know what we think of that.
I mean, there's a lot of detail in there which we need to take outside the meeting. I think the starting point for me is, Mitch, if you share with colleagues on the line what you were saying in terms of JSNA chapters. I know there was a comment made to continually working with public health colleagues. A bit of me has also got a checklist in my mind of, well, actually, who was that? And is that sitting on the oral health group? And I must admit, I've lost track of what input we've got from public health in Leicestershire and Rutland into the oral health group that was mentioned earlier. So I look to Mitch to take it forward, but rather than get into detail what it is, sort of let's share, work out who said whom to what, and then we'll take it from there.
Thank you. Are we happy to put it on for an action for next for it will be probably the end of June, for us to kind of come together and maybe plan a way? I know we're not going to solve this problem, certainly within the next year or so, I don't think, but maybe if we could work together with yourselves through as Place, that would be really useful. And maybe if our public health colleagues will update us at the end of June, and then we could maybe then look at what's happening in the future. Do you think that's acceptable for everyone with regards to yourselves from dentistry as well? I'm getting nods.
Yeah,
thank you.
That sounds, yes,
Yeah.
like a plan of action. And I think just to know, we do have a contract within the Midlands with North West Anglia Trust, I think, which covers the Peterborough Hospital. So that should be going through there. And you're quite right. We perhaps need to look outside of the Rutland area as well at some of those other services to make sure we're picking up those elements in the picture when we come together.
Thank you, Carol. And just Deborah Mitchell would like to come in.
Thank you. I think following that piece of work, we just need to find a way of drawing in any actions on this into the integrated delivery group, because we don't currently have that work stream in our plan. So we'll pick that up outside as well. I'll liaise with Mitch.
Thank you. So we'll do it for an action this time that Mitch will liaise with yourselves and then report back to the board in June, and then we'll find a way forward together, because I think we all need to work together in order to improve this. It's not going to be an easy fix. So I would like to thank you for coming. I know it's been a kind of difficult half an hour, but we really do appreciate you coming along. We'll all be working together anyway from the time from when we next meet. We'll all be part of the same system. So we'll look forward to that, and we'll hear back from you very soon, I'm sure. Thank you very much. You're more than welcome to leave the meeting if you want now to get on with your afternoons while we discuss other things. But thank you for your time.
Yes, thank you. Bye.
Thank you all very much. Goodbye.
Bye.
Thank you. Bye-bye.
Right, we'll move on to we're next on to item 9. We're way behind time. I was doing so well. I was going to be We're speeding up now. So we've got an updates and timeline. We'll receive an update regarding the JSNA. Mike, this is over to you. Thank you.
It's not, it's over to Adrian.
Thanks, Mike. And we can do this really quickly. So at the last Health and Wellbeing Board, it was agreed for the chair and Mike Sands, the DPH, to have authority to have a look at the order of the JSNA that was set out previously. That meeting has taken place. The decisions have been made. So that there is a schedule that I'll share with colleagues. But in essence, there are 4 chapters currently being worked on: substance misuse, alcohol misuse, preparing for population growth, and the Rutland military and veteran health needs assessment. Substance misuse, alcohol misuse, and preparing for population growth will all come to the June Health and Wellbeing Board for review and sign off. The Rutland military and veteran HNA, which Mitch is working on, will be coming autumn winter time currently, because there's a lot of work happening around the rotation in June. The next JSNA chapter to be started is mental health. That includes child mental health and dementia diagnosis work as well. Whilst that one's been scoped, learning disabilities chapter will start to be reviewed underneath that as well. And then following those two, a specific SEND chapter will be looked at via Rutland BI team alongside Leicestershire's, with other chapters that were originally in the plan continuing on track, but not until later on in the year, which are best start in life, staying healthy and independent, healthy aging, and then equitable access to services. And that was the agreed plan. Thanks, Chair.
Thanks very much, Adrian. I will, Mike wants to come in, and I know Ian would also like to come in if he can, around the Armed Forces JSNA. But I was just going to ask, can we just append the timetable to the minutes, that because that would give us an easy view. So sorry, Mike, did you?
You beat me to it again. That was going to be my point. Thinking about the question earlier on, I think it's important that, thanks for the update, but we'll capture that in the minutes, and then we can send that to members of the board, because it does really inform the bit about JSNA. And the other bit is, Sarah, making certain that you're cited on those chapters when they come through, so you can feed it into the 5-year forward plan.
Thank you very much. Ian, would you like to come in just regarding the Armed Forces JSNA?
I'm not sure what you mean. I was going to raise the issue of the survey, which comes up later.
Oh, sorry, cross purposes. Ignore me then.
Thank you.
Sorry, are there any more questions from anyone else? No, we've torn through that one very quickly. Thank you. So next, item 10 is the LLR Integrated Care System update. So we've got the next bit will be on the 5-year forward plan. I think, Sarah, this is over to you.
Thank you, Chair. So this is just a bit of an introduction to the 5-year forward plan, because although we've talked about it, we haven't considered it in any detail. So just a quick reminder for everybody, when the legislation changed in July 2020, that created 2 groups. One was the Health and Care Partnership, or the Integrated Care Partnership as it's known nationally. And the requirement of that group was to produce the integrated care strategy, which this group has considered. And then alongside that, a statutory organisation was established, which was the Integrated Care Board, replacing the CCGs effectively. And the requirement in statute is for them to produce that organisation to produce a 5-year joint forward plan each year. So this is 23 is the first plan that will be produced, or the requirement is to produce it and submit it by the end of June. And then thereafter, it should be updated annually or in line with the JSNAs, as Mike's just pointed out. And I think there will be some work as we update those in future years to make sure that that works effectively, I think. So the integrated care strategy, as we've seen, concentrates on the things that we can do as a system together. and the integrated five-year plan focuses on how we deliver effectively NHS services across LLR going forward. There is a relationship between all of the plans, which is described on the second slide. That interrelationship between the GSNAs, the health and wellbeing strategies, and both the integrated care strategy and the joint year forward view. And then there are things that come down that will inform the forward view, like the long-term plan and the priorities that are set each year by NHS England. We had some guidance, which I think I have touched on in previous meetings before, which effectively says it needs to be a delivery plan that delivers on the commitments that the NHS have made, the planning guidance and the NHS long-term plan, as well as aligning with things like the health and wellbeing strategies and the GSNAs, etc. We need to align it, we need to build on existing strategies and plans, and it needs to be delivery focused, which I think I touched on when I answered the question from the member of the public. And as I've just said, it needs to be refreshed each year. I have put a timeline in here, but this is moving as every day as we speak. I think that the plan now is probably to engage post election period, and then we will be bringing a version of the plan sort of May, June time. We'll need to talk to each health and wellbeing boards about their dates, which I know may not be 100% settled yet given the election period. And then we will submit at the end of June, but actually I think we will formally sign off as an ICB that plan in July, given the fact that we have got quite a number of our places are undergoing elections this year. So that is a timeline, but it is a little bit fluid still as we go through the development of the plan. There's a little bit in here about the role of the health and wellbeing boards. So there is a requirement for you to consider the plan. I think I've touched on that before, and to provide us with a statement, a final opinion on how you feel that that plan fits and aligns to the priorities that have been set in the health and wellbeing strategies, etc. And we'll do that through that engagement with health and wellbeing boards in late May, early June. In terms of what are we focusing on, so there are a number of focus areas that we're developing in the plan, and I hope that most of these things will be familiar to people, because there are things they are things that constantly the public tell us are issues and that we need to improve upon or deliver in a different way, or that are important to people's health outcomes, and a mixture of all of those sorts of things. So mental health and dementia, learning disability and autism, there's something around right place, right time. So making sure that people can get into the right services at the right place at the right time. So that's things like, how do you access primary care? How do you access urgent care, etc. Something around the management of long-term conditions, particularly around frailty and multimorbidity, from the prevention end through to the end of life care end. How do we really integrate health and social care teams, particularly around integrated care hubs? That's something we have been slowly developing over the last few years, but how do we get traction on that and move that forward? There's something there about women's health that's come much more to the agenda, particularly about the integrated nature of women's health, and it actually is a key priority for NHS England. Much more on prevention. How do we work collectively together on prevention? How do we get prevention much more embedded in our pathways? There's something about how do we continue to recover our elective care pathways and make sure that people are seen on their elective care journeys in a reasonable time frame. And then there's something around children and young people. So for each of these areas, we will have a key set of actions that will underpin and set out how we may change the pathways around those areas to improve outcomes for people. As I've just said, we will be doing some further engagement. It will be post-election period, and it will include us coming back to health and wellbeing boards in due course. And we are continuing through the next few weeks in developing the plan, doing what engagement we can, and then the post-engagement, post-election, and then, as I say, as return to health and wellbeing boards in May, June time. So that's just a whistle-stop tour of the structure of it. There'll be a lot more detail in the draft plan when we bring that forward, but it just gives a brief overview of the key areas that it will cover. So I'm happy to take any questions.
Thank you. Any questions, colleagues? Mike?
Yeah, thanks. I might be getting ahead of myself here, but I suppose I'm thinking about what do we do as a health and wellbeing board after the plan is signed off and the refresh. And I know you kind of said it will come back here for an annual refresh. I'm more thinking about the role of the health and wellbeing board to help deliver the 5-year forward plan, because it's a bit like ICP needs to get together the strategy, then it's given to the NHS, they come up with a forward plan, and then that's it. But all those areas are a bit like the NHS can't do it on their own.
Yeah,
it has to be done multi-agency. So I probably answered my own question, but whether you just want to reflect on that.
I think we probably, what we need to make sure is that they align, don't we? That's the first thing, that they're not against each other. And there may be some things that we deliver, that we say that might be best delivered through the delivery plan, for example. So then we'll need to refresh that, I think. So I think once we've got, there'll be some clear things that the NHS will need to do on their own, maybe contract with somebody or whatever to do things. But there'll also be a whole host of partnership things that will be required. And we'll just, my personal view is we need to take a pragmatic view about where they get delivered. It's the best place for it, isn't it? In agreement with everybody.
Deb.
Yeah, I agree, Sarah. And part of the role of the integrated delivery group, plus the other subgroups, the Health and Wellbeing Board, will be to pick up that plan and make sure that they still align with the strategy and that we are progressing the actions going forward. So the IDG takes not just the health plan, it takes the whole health and wellbeing plan and that alignment.
Thank you. Paul Shelton from Leicester Partnership Trust.
Thank you. I was just going to reinforce the point that Mike's alluding to, which is picked up in Sarah's slides around the best people delivering that. The NHS absolutely can't deliver everything on their own. And I think the point about the collaboratives, the networks, the alliances, whether that's through primary care networks or anything else, whether that's collaboratives just within Rutland, LLR, East Midlands, whatever level that is, the best vehicle to deliver the care and the outcomes for patients, I think is the critical way to look at it, rather than the old siloed NHS organisation being there on its own as a sort of monolith. It's the only way to deliver care. You know, there are absolutely better ways to do it.
Thank you. And I think that also, because one of my concerns, obviously from a Rutland perspective, is that we know it's about circa 30% of our patients look to Leicester, which leaves the other 70% not reflected, although the ICB pays for their treatment in out of area. From a Rutland Place perspective, an optimum pathway, so we should just say for elective care, we know the waiting times for elective care outside of areas, say at Peterborough, where a lot of our patients wait, are different to UHL and have different issues. So I think from a Rutland Place perspective, it's kind of making it's kind of square pegs in round holes thing coming up, and it's how as a place in a system can we bring that story together, because otherwise we're going to have a forward plan and a strategy that actually only reflects a small percentage of our population, which is tricky from a Rutland perspective. Deb, you wanted to come in on that?
Yeah, that's a really important point, Chair. And I suppose just for clarity for the public listening in, we have a responsibility around delivery on the health plan, but also for those services that go outside our patch. And so our health strategic group that sits below the IDG has input from other organisations outside LLR, and we are working in partnership with them have those continual conversations about the services that they provide. And Sarah's also on one of the place groups outside LLR and has that link directly in.
Thank you. And as I said, I know some of the work's going on, and I suppose my concern is it wouldn't be reflective. So we need to ensure that we reflect that work.
I think that's a good point, and I think I will pick that up, particularly in the elective care stuff. I'll go back to the team and see how we can reflect that, because the proposals that we're saying are around elective care are for the residents of LLR. So that's irrespective of whether they get treated by UHL or Peterborough, for example. So the actions that we will put in place to recover the elective care waiting lists need to be actions that can be delivered in Peterborough or Kettering or Leicester, really, don't they? So I will make sure we pick that point up. That's a valid point. Thank you.
Thank you. Was there any other points from anyone? No, I think we just look forward, I think, to the draft. I think what might be helpful, and I'm very conscious that we're going into PERDA, into elections, and I think our annual council is not until the end of May, is it? And we're looking at our first probably health and wellbeing board looking towards the 27th of June, which is very late. It might well be, and I appreciate we're in PERDA until the beginning of May. We are business as usual, so I would maybe ask Sarah if we can share a draft copy with members of the board as soon as possible. And I know some members will pick up with their other hats, but I think as a Rutland board, if we could action that we have first sight of the draft as soon as possible, that we can share to the board so that we can reflect, because otherwise we're going to have, there will be a 6-week period where Rutland as a place, as a health and wellbeing board will be a bit dark. We won't know who the chair is, we won't know lots of things. And I think we need to kind of, it's really difficult. The timing of this is not good at all. It's very mucky and things with elections. So if I could ask that a draft is shared as soon as possible, we can share that to the board and get comments. That would be great.
Yeah, I'm sure that will be fine, just with the caveat that it will be a draft and it will continue to be evolved as we go through the next few weeks. I mean, I have fed back up to NHS England the difficulties of the timelines, given that we've got local elections, and you know, a lot of my peers are in similar positions. So yeah, we'll do what we can do in relation to sharing a draft.
Thank you very much. So we would just note in the contents and the accompanying presentation, and we'll put that action point through if that's okay. And I think next we are back to you, Sarah, for the Rutland Memorial Hospital. Sorry, I will put my teeth back in. Rutland Memorial Hospital feasibility study. Thank you.
Thank you, everybody. So I'm pleased to update to the board about the progress that on a business case that we have been working on with Rutland County Council in relation to supporting a request for developer contributions to create an enhanced procedure suite at Rutland Memorial Hospital. And this was part of the health plan, if you remember, that we set out. This is something that supports the priorities that we've set out in that health and wellbeing strategy, and particularly the health plan that was part of that. And it will support the needs of residents by providing care closer to the local population. The scheme is about enabling infrastructure development that would underpin the expansion and transformation of services locally to provide more outpatients and diagnostic services at the Memorial Hospital. We have developed that healthcare plan, the Integrated Care Board has, for Rutland Memorial Hospital to transform the community asset into more of a community health and wellbeing hub. So our proposals for the enhanced procedures suite are part of that, utilising the currently unused theatre space at Rutland Memorial Hospital, and would support wider aspirations by providing things like pre-assessment and rehabilitation services for elective outpatient lists, services around dermatology and respiratory outpatients, some stuff around eye degeneration and renal and cardiology medicine. The proposals support the national priorities set out in the NHS plan and are conducive to the NHS test for sustainability, which stresses that we must use our assets and drive forward transformation. As I've mentioned already, the scheme would align directly to the existing 5-year vision for Rutland's Health and Wellbeing Plan. It presents a clear vision for the future with 6 strategic health and wellbeing priorities, if you remember, for Rutland. And this proposal will specifically enable 2 key priorities to be delivered. One is making access to health services fair for all Rutland residents and preparing for the population growth and change. So the LLR ICB is already working to develop the new integrated care models as a basis of bringing additional services into Rutland in the context of local need. A cross-cutting priority of the plan for Rutland is to tackle health inequalities, which we are keenly felt in rural areas like Rutland, and clearly articulated by residents who want to see improved access to primary care, outpatients and diagnostic services, less travel time for non-complex elective care and better use of local health and care facilities through innovation, and this proposal will do that. We have also been actively engaged from the outset in a separate development of an exciting and truly innovative proposal by the Rutland County Council for the local and surrounding area around the development of the Moby Hub and Meditech Research Centre. So we're committed to continue to work with our colleagues in Rutland to support these proposals in the next stage of their development, recognising the significant impact that both these proposals and enhanced procedure sheet could have on the Rutland Memorial site. And the local healthcare provision, because if you remember, that bid for the local proposal was at Rutland Memorial. This will bring an opportunity for workforce collaboration between the sites on the same footprint and enable opportunities for collaborative working between healthcare providers and the Meditech Centre to support local innovation. So the above landscape provides a clear need to plan and invest now for the delivery of the local healthcare provision in the context of the health and wellbeing strategy and linked vision for the healthcare, local healthcare. So we'll continue effectively to work together to deliver those things. So thank you.
Thank you, Sarah. And just before I bring Paul in, I would like to congratulate LPT on the reopening of Rutland Ward. It was really welcomed, and congratulations for doing that work on time. It was a fantastic achievement. Thank you. I don't know whether you wanted to comment on the workaround.
I was just going to give a brief update, Chair, in terms of the work. Whilst the ward and the internal areas have completed, as you've alluded to, as of the work around the replacement boilers, we've replaced throughout with new taps and sinks. The electric has been replaced as well. You will notice, though, that the roofing works continue. There was a bit of a delay on some asbestos, which is not uncommon in a building of that age, but that will continue through to the end of May. We will finish the whole thing on time. So yes, the ward's back in use, delivered on time, as you said. And I think, you know, if that's the basics and Sarah set out the opportunity of the future, I think it's a really good future for Rutland Memorial.
Thank you very much. I don't know whether any other colleagues would like to comment at all.
Yeah, I think Rutland people really have always wanted Rutland Memorial Hospital to stay and to be expanded and to be better used. So I welcome the developments, etc. One question I'd like to ask is there going to still be a palliative care suite at Rutland Memorial Hospital? There was one, and I don't know whether it still exists or whether it's going to continue.
I don't think it does still exist at the moment.
Let's just go back.
Yeah,
It's something that we picked up when we were doing sort of engagement about what people are wanting, and several people mentioned that they would like to see a palliative care suite there. Used to be the Karen Ball suite.
I couldn't remember I had ball in my head, but I couldn't remember Karen's name, so it was eluding me. But yes, we did used to have the Karen Ball Suite. I think we could let partners go back and maybe we can confirm that.
What I do know is there's a lot of work going on around palliative care, around different models of delivery. So it might be worth having a presentation about that actually. We can go back and have a look into that. Yeah.
That might actually be quite timely to maybe look at that for the, we'll think of that when we come to the forward plan, because I like you, I think that would be a timely thing. If there's no more comments, I will wrap this up. I will say actually this news is really, really welcomed. As Janet's alluded to, the future, and certainly as chair of the board, Health and Wellbeing Board, one of the most common questions I'm asked is regarding the future of Rutland Memorial. It's a well-loved hospital. The fact that we have had the works with the wards reopened, the fact now that we're looking at this procedure suite, which is such a major step forward, bringing that operating theatre, which to my knowledge hasn't been up and running for at least 20 years. So that's such a huge step forward. I don't know whether it ever did work in that guise. I can remember my brother having his tonsils out many moons ago there, but I don't know whether it was ever in its current guise. I know it's just a lovely shiny model under plastic of what an operating theatre looks like. So to actually use it will be most welcome. And it's also exciting that the LUF bid was successful and we were awarded. I need to stress obviously that the LUF bid was to do with health economy rather than services, and that is bringing the research and things in. And however, we have had fantastic engagement from our colleagues in the integrated care system around that, and there is great excitement. And I think it's a fantastic opportunity for seed funding into that site, and will ensure the longevity of Rutland Memorial at the heart of Rutland Care, which I think all of us around the table, colleagues at LPT, colleagues within the ICB and everything, look forward to. So again, I'd like to thank certainly colleagues at LPT for bringing that forward, and the work done by our colleagues in the ICB. I know we've all worked incredibly hard behind the scenes for what seems like years, but I know it's only the last year for us, but it's finally kind of, we're getting the cherry on our cake. So congratulations to everyone on the board. Thank you. So next we'll move on to item 11, which is the joint health and wellbeing strategy. Catherine, we're over to you, and I'm going to be quicker. I will, I promise.
Thank you. Just wanted to highlight that work is continuing to progress with delivery of the strategy action plan. This is all in my report, but there are a few highlights just wanted to mention. There's a new mental health pathway in place, which has been produced by the mental health subgroup, neighbourhood subgroup. Armed Forces survey has been commissioned, which I think Ian will talk about later. There's a specialist palliative care virtual board that commenced on the 27th of February, supporting priority 6, dying well, and all the additional roles reimbursement scheme, the R's roles, have been recruited to, which supports equitable access, priority 4. And I just wanted to mention around hospital discharge, which supports priority 3. We made some changes to how this activity was being measured to make more sense. And just wanted to highlight that from January, the team assisted 34 discharges. So demonstrating prompt and safe hospital discharge, we can show that 25 of the 34 discharges took place within 48 hours of the patient being medically fit, while 12 left on the same day as being medically fit. So good turnaround. Next steps for me is to look at completing an annual review of the strategy at the end of the first 12 months and look at what progress will look like over the next 12 months. Moving on to the outcome summary report. There continue to be areas where Rutland performs well, and I have mentioned this in previous reports. They include cancer screening for bowel cancer, mental health. Rutland performs well for admissions for alcohol-related harm and emergency admissions. There are areas where Rutland is performing comparatively poorly. And one of these is screening for breast cancer, conversely with cancer screening. The proportion of children receiving a 12-month review, population vaccination coverage for HPV for 12 to 13-year-olds and females, and also social, emotional and mental health needs in school pupils. But importantly, I wanted to highlight that we will begin looking at work with priority leads to devise strategies to look at making improvements in these areas. I'm also working on a health and wellbeing board annual report that's in draft at the moment, which will look at all the achievements that have been made over the last 12 months. I've had some really good contributions from people. So that will be shared when that has been approved by the chair.
Which she will do. It's on her to-do list.
Thank you.
I just wanted to pick up one thing, and that is the proportion of children receiving a 12-month review. Just because it's not clear to me, is that children looked after?
As far as I'm aware, that's children in children's social care.
Yeah, so that's children looked after. I just wanted to, just because with my other hat as children's champion, I sit on other boards. I just want to reassure the board that our Dawn Godfrey, Director of Children's Services, that this is receiving recognition and is being pushed up further. I don't know whether Dawn wanted to say a few words regarding it. I'll let you come in, Dawn.
Yeah, just on that. Thanks, Chair. There is an issue with the review health assessments for looked after children. We've got the Children and People's Collaborative meeting, which is the system leaders meeting on Friday morning, which I chair. And that's actually on the agenda. So I've got a report coming from LPT specifically around the looked after children health team. There is major capacity issues regarding which is impacting directly on that measure. The other element to that, though, is that we do have quite a high number of children who are placed outside of LLR. So that makes it more difficult in terms of, it's not all completely within our control in terms of the review health assessments. So we've got a high proportion of children who are placed in neighbouring local authorities, but of course they're not our health, they're not the same ICB or health system, so that makes it more difficult. But it is something that we're meeting as system leaders on Friday morning this week.
Thanks very much, Dawn. Mike, did you want to come in on that? Oh, okay. I did have a question for you as well, which possibly is a question for you. I just wanted to pick up the HPV vaccinations, which I think comes under public health. And that was my question. Does that sit under public health or does that sit somewhere else? That was my question.
That's our dear friends in NHS England, so we can invite a different team back.
Oh, the joys.
Or actually, well, the longer version is, yes, it is them. If you were looking to increase it, that's when we get drawn into a multi-agency bit, because we do have a role to play and think about how do we work with schools and partners to increase uptake. But But yeah, in terms of responsibility, it's NHSE.
Okay, we might need to flag that. I'm a real stickler on around HPV because it is cancer prevention at the end of the day, and it's really important that our young people have access to that. And actually, sometimes it's around educating families, young people, and parents about what it actually is. There's a lot of misinformation around HPV vaccinations, and I think it is strongly important if there's one simple thing we can do to prevent cervical cancer, and there is also some links to prostate cancer in men as well through HPV. This is a very, very effective, simple way to prevent that. I shall get off my high horse on it. And Mike, if you want to come back.
I mean, yeah, wouldn't disagree with you. I suppose in my mind, there is a little bit of a parallel with dentistry, which is why I think it would be worthwhile bringing back here in some way, shape or form, because it's the same kind of issue. When we've raised this at things like the LLR Health Protection Board, you tend to get an LLR perspective on how the programs are being delivered. And from that point of view, of course, Rutland's coverage is not bad, and the focus tends to be on the city. When you try and dig into the detail, that's when some of the data and understanding of different ways of looking at inequality and what do we do about it ends up getting a little bit kind of lost at a particular level. So maybe with a bit more prep than the dentistry one, it'd be worthwhile kind of going, let's start from where we are in Rutland and think about what we can do locally to get it forward. So it'd be worthwhile, but it's the same kind of thing. It gets lost in the Rutland needs to have a specific look because it gets lost in an LLR kind of focus.
Excellent. We'll tip that to the forward plan, but I think if we maybe have an action for us to have a conversation about where, because I think we need to give them guidance on what we'd expect. So what would be best value, because it's not just around the HPV, there's that whole healthy, it is a big program. So actually it would be, I think, really useful from a board perspective to see where we are, and then we can focus on that. Sorry, Dawn, you wanted to come in.
Yeah, it was just to add to that, actually, a couple of things. Just in terms of the HPV take-up, if there's certain school, I haven't been made aware of whether it's across Rutland or Rutland, I'm thinking secondary schools particularly. So whether we need to do some targeted work, that would be my first question. But the second thing is, actually more generally in terms of our health and wellbeing practitioners who are part of the 11 plus HCP program, that's something that they have very much in their line of sight is improving that kind of awareness and the take up. So yeah, I think there's some real opportunities in linking with what Mike's just said.
Yeah, and it's worth us noting, I've just quickly checked, the data was from 2021. So because we know the HPV vaccination is usually delivered through our schools, that will have been affected probably by COVID lockdowns and school lockdowns. So sorry, Mike, did you want to come back on that?
No, it was going to be that one. You're right. I mean, 2021, we were still in COVID. My understanding, Dawn, is it's not specific schools. I think we're all still suffering a bit of the kind of post-COVID, not as bouncing back as much as it should have done. So they're kind of universal issues around perceptions of safety and efficacy, all the kind of misinformation around COVID, and people fall out the habit because almost like you need to build in the habit of being at school to understand that your jabs are coming through. So yeah.
I think it's certainly worth us putting that on the forward plan, and we'll maybe have a discussion together about what we think would be ideal. Thank you. Sorry, Janet, and then Ian, and then, sorry, Catherine, did you want to come in? Apologies.
Sorry, I know I've thrown a few stats out there, and this is exactly the reason why I wanted to bring it forward for the discussions that we're having, to actually look at how we can work together to understand the data better and how we can actually make some improvements in those areas. So just wanted to raise it. Thank you.
Brilliant. So sorry, we had Janet and then Ian afterwards.
Yeah, thanks. I've been madly scrolling through because I saw that we were very low on breast screening, but was that during the COVID lockdowns? Were the stats from then? Because at that particular point, the breast screening unit did not come to Rutland, and a lot of people were having to go to Leicester for their breast screening, and we were actually as Health Watch picking up a lot of feedback about women not wanting to travel that far?
Yeah, the data all comes in at different times. So I'd have to answer your question, I have to go back, sorry, and look specifically when that data was recorded, but it could well have been then.
I
Yeah,
think it
yeah.
was, I can't find it now this minute. But the other thing that I wanted to actually flag up, and I know this is a national policy, is that breast screening goes from the age of 50 to 70. And people that want breast screening, people are older or I think younger who want or need breast screening have to they want it for peace of mind rather than because they've got any symptoms, have to actually ask to be able to have that screening. And people in Rutland aren't always aware that the van is tucked away down here somewhere when it's breast screening time. And I think I'm picking up from sort of my peer group that people want to be notified when the van is here, even if they're not in that age bracket that is screened regularly. I don't know whether you can do anything about that.
I'm looking at Deb, who looks like she wants to come in.
Thanks, Jan. Thanks, Janet. So a couple of things. I'm going to pick up that point and check that it's not historical, because I looked at that. I've asked the question about latest screening for breast care. I don't think even if we told the local population that people can just book in, so people are invited for that screening and for symptomatic, and we're just keeping pace with that demand. So I can pick up with you outside. So I'm not certain how we would take that bit forward. But certainly, if people are concerned around symptoms, then there is obviously a way to get that screening.
I think, sorry, no, I was going to say, I think it might be useful, going back to what Mike said, it might be that people are out of the habit, because we all got out of the habit of doing healthcare in 2 years. So it could be that it might be worth, and I don't know whether we would have that data of knowing how many people are coming forward from screening who have been invited, because it might be that from a board perspective, maybe we need to do some comms around coming forward and around reminding people of that. That might be really useful. So if we could maybe look at that, that might be useful moving forward, because it might be a case of I know, as you say, I know there was for a while screening was further, you had to go further away and things, and people might not be aware that those sort of services are restarting, because a lot of people just hear that the NHS has got massive backlogs and they aren't aware that some of the prevention services are back up and running reasonably well.
I have heard, just from my own particular village, 2 women that are over 70 or were over 70 when they actually had that. They requested to be breast screened, and both of them actually turned out to have cancer, and were both caught at a very early stage and have been completely cured. So I think there is some mechanism, but I don't know what it is, whereby people can request, but I don't know what it is, but I think I need to know when and how.
We'll pick it up.
We'll talk to you. Yeah.
Yeah, we'll pick it up outside, and obviously I would encourage anyone who's got any signs, they should be checking themselves regularly, but also to alert your GP as soon as, because the waits for people that are worried or have picked up and have concerns from their GPs, you are still being seen very quickly. So I wouldn't like people to believe that there is a delay on the 2-week wait. There isn't. The breast service, certainly that's run out of Glenfield Hospital, is second to none. So I would, anyone, as ladies, we are meant to check so we know ourselves, and to really do encourage people to contact their GP.
Yeah, can I just add that men can get breast cancer too?
Yes, thank you. Sorry, Ian, over to you.
Thank you, Chair. I just wanted to say thank you for commissioning the Armed Forces survey. I'm very grateful, and in fact, I'm quite excited by it. Sorry, I know it's a bit sad. I think it's important that when we produce the report, if it can be a public facing report, that would be really useful, because I think a lot of people will be interested in the results, and hopefully it will be rich, and will provide evidence for groups like the Ministry of Defence's Covenant team. They're always looking for evidence about the needs, particularly of service families. So this could be really, really useful to a lot of groups out there, families, federations, etc. Thank you.
Thank you, Ian. Did you want to come back or no? You're fine. Thank you, Ian. Do we have any other comments on those? No. So we will move on to item 12. Again, this is over to you, Catherine, for the Better Care Fund.
Sorry, Chair, do you want me to run through these slides? Or shall I leave that for now as we are short of time? Sorry,
No.
Sarah has covered a lot of it in her presentation.
I was going to say, I think we can actually probably take it as read. They're very self-explanatory slides. They are out in the pack and in the agenda. So
Yeah.
members of the public will have the link to be able to see them. So yeah, I think if you just talk at them rather than going through them, that would be fantastic. Or we can go straight to questions, whichever. Yes.
It was just, I was asked just to explain, asked to just do a few slides to do very basic, brief outline of our Health and Wellbeing Board, how we fit within the system and the main responsibilities for the elements within our system. So I just tried to bring that together in a few slides. I guess it's more aimed at members of the public.
So yes.
Can I just ask on that? I was going to kind of raise this in relation to your last agenda item. Slides are fairly self-explanatory, as you say. The annual report that you talked about for the Health and Wellbeing Board, we kind of always done them, or occasionally we've done them, and they are, as you say, an annual report, and we go, look at the great work we've done in the past. I just wonder if there's an opportunity to almost kind of use it to set our stall out for the future by kind of putting a bit of a summary about what it means to be the Health and Wellbeing Board in the context of the partnership. It picks up on some of that loop back comment with Sarah about the 5-year forward plan, just so we've got a kind of a written statement of where we're going. It's almost kind of built on what's there. I don't know if we can do that or whether it would be useful or not.
Yes, the draft does include next steps, but definitely take that on board and have another look at it. Yeah, will do. Thank you.
Do you want to come? No? Any other comments? No, I think this is really good. Kind of it says what we do on the tin, and I like it. And it makes it sometimes quite, yeah, it simplifies it, because sometimes we just talk about strategies and we confuse ourselves with names, and I see this and I see that, and strategy this and strategy that. So thank you. It does kind of set out really clearly what we do. So if it's okay with you, I will forward that round to other members as well, so that they can, it clearly demonstrates. Thank you. So next is our update from our subgroups. We've got Children and Young People's Partnership, but Councillor Wilby wasn't able to join us today. So I don't know whether...
Sorry, you missed an item.
Oh, I've missed an item, sorry. I thought that's what I was doing.
No, that you just done was the item before.
Oh. Scrap that. Sorry, Dawn. Hold on. I've messed up. Sorry, everyone. Better Care Fund. I thought that's what I was doing. I thought that's where I was. I was there. In my defence for everyone, I'm a bit space cadetty today because I've had COVID. So I'm COVID and ME don't mix in brains. So sorry. We'll go to item 12, Better Care Fund, which I thought we'd wrap. And over to you, Catherine.
I'm sorry. I think those slides kind of came in between, so I apologise. This again will be very quick. I brought to the last board some information on the Better Care Fund, Adult Social Care Discharge Fund. So that commenced in December, and we sent a plan through to the national team in December, and throughout January, February and March, we've been submitting fortnightly reports to give updates on schemes that we've used this additional money for. And just wanted to highlight that what's been really good use of the fund has been reablement beds, which were commissioned at Rutland Care Village, that have been very well used. We've had been able to give some staff at hospital team overtime, so that they've been able to work at weekend bank holidays. And we've been able to give retention bonuses through to my care staff, which is particularly for fuel costs. And I wanted to highlight these schemes have contributed to the flow of Rutland residents being discharged from hospital in a timely manner to appropriate discharge destinations. And it's really promoted the health and well-being of Rutland residents. Just wanted to mention as well that the budget levels for the Better Care Fund for 2023 to 24 and 2024 to 25 are coming through now. So we are starting to prepare. We've had a meeting with some budget holders to look at whether the schemes that have been in place over the last year are still required and are still meeting the criteria of BCF. So that piece of work has just started, and I'll keep the board updated with progress.
Thank you. Deb.
Thank you, and thanks, Catherine. And just to remind the board that part of the role of the IDG is to oversee both agreement of the Better Care Fund and the implementation. So I think the process that Catherine's described is the start point. But the IDG will formally look at plans for the forthcoming years around those budgetary elements, just to ensure that we are still making the best of the resource available, and that it's matching those ongoing needs for both health and social care.
Thank you. Any other comments at all from partners? No. Thank you very much indeed, Catherine. So we're meant to be doing things for this. We're noting, it's fine. We're noting the content of the report, and we're noting that the fortnightly reports have been submitted. So thank you very much for that. So next we're over to updates from the subgroups. We're back in line. I think, Dawn, are you able, Councillor Wilby hasn't been able to join us today. So are you able to give the update? Thank you very much.
Yeah, no problem. So Children and Young People's Partnership met on the 16th of February. There's progress being made against all of our priority areas, but some key headlines that I want to report in. The first priority is obviously the one that's in our joint health and wellbeing strategy, Best Start in Life, and priority 2 in relation to physical and emotional health and wellbeing. There's been some really good progress along those priorities since the last health and wellbeing board. So safer sleeping courses and paediatric first aid workshops have been delivered through our children's centre, and we've had over 500 children brought and seen to our health visiting clinics that are taking place in our children's centre, which is really positive. One of the areas where we've had a lot of focus is around our priority around children who become vulnerable in their education, and that includes children with SEND. I'm really pleased to report that permanent exclusions have been reduced, with only one this academic year. And we've also launched our anxiety-related non-attendance programme, which is supporting our children and young people to remain in school, and or to get them back into school if they have had anxiety-related non-attendance. 100% of our schools have signed up to that programme. Training with the schools is pretty much completed. And as I say, I've been really pleased with the level of engagement with our schools, with all of them signed up. Clearly, there's a continued risk in terms of special school places in Rutland sufficiency, and that continues to be a high focus area for us. That's all I was going to say today, but I'm happy to take any questions. There's much more detail, obviously, I could go into, but I'm conscious of time.
Thank you, Dawn. Is there any questions at all for Dawn? No, thank you very much. We will next move on to Integrated Delivery Group. Deb, over to you.
Again, I'll keep it brief in the interest of time. So work has been progressing across all of our work streams. We saw the first version of our risk register at our March meeting. Each of the individual programmes have collect their own risks, but we were keen to look at the overall risks. That draft version, we had some good discussion in the March meeting, and we've asked all risk owners to go away and look at their risk scores and mitigations, and to ensure the actions that there are put in place are meeting those risks, and to allow us then to formally highlight any risks up to the Health and Wellbeing Board. So we're just trying to formalise that process. We also discussed what our next year's, the next 12 months can look like around the health and wellbeing strategy and our implementation plan. And again, at our April meeting, we will be looking at new actions and closing off previous actions. We had a good discussion around comms and engagement, and the need to be a bit more proactive on engagement around our transformation schemes. And again, there will be a topic in our April meeting where we will consider the engagement that's gone on across a number of schemes. Healthwatch presented their initial findings on their interim view visits to both the Oak Emergent Care Centre and Minor Injury Centre, I should say, sorry, and Leicester's ED department. Really good insights there. Janet might want to pick up on some of that. The other thing that we did talk about, Chair, and that's something that I want to pick up with you, is that now that we have a number of subgroups of the Health and Wellbeing Board, we'd like to review what each of those subgroups are looking at in relation to the strategy, and how we report back, and how we make sure that we get sort of a joint view about what's going on. So, you know, whilst having more subgroups is really important in terms of delving into the detail, what we don't want to lose is the essence of the whole. So hopefully we'll pick that up outside the board, and then maybe report back to the next board about actions to sort of identify.
Yeah, thanks. We'll add that as an action for us to pick up outside. Does anyone have any questions for IDG? No, thank you very much, Deb. We'll pick that up outside the meeting. So next we have welcome to the Rutland Mental Health Neighbourhood Group, who are going to give their first update. I'd like to welcome Emma Jane and Mark Young, who are online today. You're always welcome to come and join us in person if you want to in the future meetings. But over to you, Emma Jane.
Thanks, Chair. Thanks very much. I'm going to start with just a few sort of points and highlights of what we've been up to and things that are happening out in the community. And then I'm going to introduce you to Mark, who is our Senior Mental Health Neighbourhood Lead, who is very much the driving force behind all of the strategic side of things. But just to give you a couple of sort of points that have been real things that have been happening out in the community, which I think is important, as well as we're looking at strategy. We have, obviously, with the Crisis Cafe round of applications closing on the 10th of March, we do actually have Rutland applications, which is fantastic. And I am on the panel, which is meeting on the 31st of March to assess those applications. And I'm very hopeful that we will be successful in able to bring a Crisis Cafe into Rutland, which is fantastic. We have recently been working with Leicestershire Partnership Trust, and we have a new reablement worker that has just started in the last week, who is using the 3 conversations approach to focus on how we support those individuals in our community with personality disorders. So that's an area of work that we identified was a specific need, and we have some resource for it. We have recently had our first sessions of a new group mental health support in Rutland. The groups haven't been running for the last 4 or 5 years, and our community mental health worker, Alex, and our GP, Dr. Cora, have been running a very, very successful group, which has had really good feedback, and they will be starting their second group in April. This enables people to go on to self-help and to form their own support groups going forward. So really, really pleased with that. I have been talking to the Carers Centre from Leicester today, and they have secured funding for a new mental health and wellbeing support group for carers. They're just working out what that will look like, but they're envisaging that it'll be a mixture between one-to-one, face-to-face, and support groups for carers. Obviously, understanding that carers' mental health and wellbeing is absolutely as important as the cared for. The anticipatory care pilot, which is focusing on increasing the dementia diagnosis, which we know is something that we are below the national average in Rutland. The pilot continues to develop, and we are looking presently for a venue for the memory assessment clinic to come back into Rutland. It used to be at the Rutland Memorial Hospital before COVID, and hasn't been in Rutland since. And we're making great strides to actually bring that, and also a wraparound professional marketplace, so that people can actually come and find out what support's available for them in Rutland when they are attending that memory assessment clinic as well. The one risk that I'd like to highlight to the Health and Wellbeing Board is that the mental health GP who works 1 day a week, Dr. Cora, the funding for that post finishes in July 2023. It has been incredibly beneficial to have a focused GP working on our mental health transformation. And I have been emailing Deborah and various other people to try and secure funding for that post to continue beyond July 2023. So that's just a few little highlights that I wanted to pull out in addition to the report. But I want to just hand over to Mark now so that he can just fill in the gaps on the report that he's given to you about where we are with the mental health strategy.
Yeah, good afternoon all. I'm Mark Young, so the Senior Mental Health Neighbourhood Lead for Rutland County Council. So as Emma Jane sort of said, we've kind of created our strategy. Again, that's looking at what we kind of want to identify as far as any priority groups, any of those key areas that we want to kind of look at. Tomorrow we're actually meeting as the group to go through some of those actions that we've kind of set out on a kind of an action plan. And we're actually trying to take kind of ownership of what do we want to actively get involved with ourselves, actually what do we want to look at, and sort of, yeah, I suppose just look at kind of what's out there. The group itself has been kind of, I suppose, changing as the months have been going on. We've been getting sort of increased new members where we've kind of highlighted perhaps there's a need for, say, someone from the armed forces to attend, someone from the farming community. So we're trying to identify those areas where we know kind of that's going to be a key area where actually we felt people would be sort of beneficial to join the group. As far as some of the community things, so we've been attending lots of, I suppose, community engagement events as far as kind of my particular role itself. And again, that's looking to kind of deliver that kind of integrated neighbourhood approach where we're working with local sort of voluntary sector organisations. And again, those have been kind of attended, really quite popular from the sort of local population as well. There was something that Catherine touched on earlier about the mental health pathway. So we produced that. It's a much clearer map of where people go to. And actually, as James has been commenting about Dr. Cora has been kind of assisting us with kind of getting that kind of as clear as possible for people. So that's something we can distribute to people. I think other than that, Jane mentioned about the crisis cafes. So again, we were supporting local organisations who was showing that kind of interest in becoming the first crisis cafe in Rutland. So we know kind of how important that is. And as Jane's on the panel, we're hoping that there will be that successful applicant. So I think that's the core bits of work we're doing. As I say, we will meet tomorrow as the actual neighbourhood group, actually go through kind of what do we want to focus on as that kind of neighbourhood level.
Thanks, Mark. So, Chair, I open to questions.
Thank you. Does anyone want to comment? Janet?
It's a comment, not a question.
I'll have that.
It's just to say that Health Watch Rutland has been working with Health Watch Leicester and Health Watch Leicestershire on dementia experience, the experiences of people living with dementia. There has been a report that's now been sent off in draft form for the whole LLR region, but we've actually pulled on the data to extrapolate the Rutland experience, and our report is just about to go this week, hopefully. I don't know whether it's to you, Emma, but I had an email from Tracy earlier in the week and she feels it's good to go. We're just waiting for a couple more comments from other people and then should be getting it fairly within the next few days, I think, unless there's any adverse comments. But that looks into particularly why we've got an under diagnostic rate as well.
Thank you. Dawn, did you want to come in?
Thank you. Yeah, it was just a question, Mark, around engagement with children's services and whether there's an engagement with the, particularly in thinking family hub. My sound keeps dropping out, so I might have missed it, and I apologise if I did.
Yeah, no, that's fine. We do have kind of members on. I'm actually a member of Family Hub myself, so it is something that I'm kind of feeding anything back that's certainly relevant. But we do have people kind of as far as members within our group from kind of children's sort of young services. So yeah, we make sure that kind of representation is particularly there in the group, because it's not just 18 plus that we're looking at all ages as far as this support group.
Yeah, no, brilliant. Thank you.
Thank you. Any other comments, Deb?
So just on the issue of the GP session, I'm still exploring ways of that funding continuing, Emma Jane. I've got a couple of calls out and I will come back to you.
Perfect, thank you.
Thank you. I would say the pathway that you've done, it might be really useful actually if we could append a copy of that to the minutes, so members of the board will see it, and ditto when the Health Watch report is available, please. That would be great to share with members of the board. Thank you. So thank you both very much, and we'll see you again next month, next meeting. Thank you. And next is the Staying Healthy Partnership, and I think that's over to you, Adrian, isn't it?
Yeah, double act this one. So just to say that we were due to meet yesterday, but we postponed the meeting in the end because we didn't have health colleagues representation there. I presume something happened and everybody didn't arrive. But actually, without health colleagues, we couldn't have the conversation. So that's still something we need to pick up outside of the board. Effectively, there is a plan now for the outcome of the inequalities workshop that we had a few months ago, which I'm going to hand over to Mitch to start going through. We want to go through the plan with Staying Healthy Partnership just to make sure that everybody around the table is in agreement with bringing that plan here for a formal sign-off at the June Health and Wellbeing Board. But I'll hand over to Mitch just to go through the basics of the plan.
Thanks, Adrian. Yeah, so development session was delivered at the end of January, which a lot of you would have been represented at, along with the Staying Healthy members. So there's a lot of tangible actions that we could take away from that as a Rutland as a whole picture. And some of those are in existing work streams, which we've been communicating with for those to take them forward. In terms of the health inequalities plan that we're looking at for the Staying Healthy group, you'll recall the health inequalities needs assessment plus development session. We talked about working at very small areas of Rutland, so focusing on Rutland within rather than comparing to regional, national comparisons, etc. So what we're looking at is some of the areas that we're identifying additional needs. So this is working at 1,000 population, 2,000 population, real small communities where we can get into detail with them. But looking at very much engagement focused as an initial step for this, which was resonating in the development session, that needs to happen, which we agree with, and very co-production based, focus on strength-based working, not on a deficit model, starting from a blank page with that community and just really understanding what assets are important to them and looking at how we can support and build from that. So not looking at what's missing, looking at what their strengths and assets are, whether that asset is infrastructure based, whether that's person based, whatever it is. We don't want to preempt that. We don't want to go looking for it. We want to start with what their outline is, them assets. So that is the plan in terms of an approach. Like I say, I could go off looking at evidence base of what works, what doesn't work, but we don't want to do that. We want to start from a blank page with the community based on the priority areas that we identified in the health and quality needs assessments, having that discussion with the community, is taking it away as professionals and identifying opportunities for action from that, the community going away and doing the same, coming back together, discussing those options, and then agreeing a proper plan to take that forward. So we wanted to start that as a pilot scheme in one small area in Rutland, which, like Adrian said, we were looking to discuss yesterday, but we'll be looking at rearranging that to take that forward as a discussion and then bring that back to Health and Wellbeing Board, hopefully in June, to really delve into that plan and understand whether there's agreement that we should take that approach. So that's it in essence. Like I said, there'll be more detail to follow, but that's the intention alongside the bigger pieces which are being covered in the work streams. Happy to take any questions.
Thanks, Mitch. Any questions, anyone?
That sounds a really good approach. I'm not quite certain what happened yesterday, but we'll pick that up offline. Certainly not an intention from health, not to attend. So yeah, we'll pick it up.
Any other questions? No. I think that does sound like a really exciting piece of work, and we look forward as a board to hearing it. It seems like a really fantastic way of really looking at our communities, which will always be smaller than other communities. So thank you. Right, next we're on to the review of the forward plan, which I'm hoping my friend to my left has been picking up as I've been throwing grenades into this as we've gone along in this meeting, because I seem to have added quite a lot in, haven't I? So our next meeting is scheduled on at the end of June, on the 27th of June. That's subject to full council, so it will be confirmed later. So at the moment we will have election of the vice chair, then primary care task and finish group survey.
Don't quite know what those two primary care things are, if I'm honest. They wouldn't be for my team anyway, because I don't lead on primary care.
Oh, I know what they are. I do know what they are. They are the it's the primary care, it's the strategic review, the primary care, what's it called? my brain it's irritating me now.
It's getting hotter in here.
It's not just that, the clogs aren't working, they're not just connecting, and it's so frustrating.
Should we pick this up offline? And
Can we
then
pick up,
agree?
it is definitely yours, it was Joe Clinton's, it's the long awaited primary care strategic review, that's what it should be. We'll pick it up offline, it is there for, I don't think, I have a feeling it's not going to be ready for June, from what Joe said to me. So we will pick that up. It is carried forward. Yeah. And then the primary care strategy. Is there?
I think that those two kind of overlap, I believe. So yeah.
There is a primary care strategy.
Yes, so that sits in INT, integration and transformation. So I think bringing a primary care strategy to the next meeting would be good, and I'll invite an appropriate colleague from my team to.
Thank you, Deb. Your name's now down on that, unfortunately. And then we do have Sarah's going to be bringing, we definitely need the 5-year.
The 5-year.
Yeah.
And then maybe there's an integrated care but we'll need to confirm that through the data.
Yeah. So So the health and wellbeing partnership strategy. Yeah. And then we've got the Armed Forces personnel report from Public Health from Adrian and Mitch. The Health and Wellbeing Board annual report. This meeting's becoming large again. And then what have I added today? Quite a bit.
Quite a bit. What I'll do is I will go through the minutes. I will pull together a draft forward plan and I will send it out.
Yeah,
for us to double check, because I think there's been a bit of confusion about what's going and what isn't.
Because we had 3 JSNA chapters coming to that, Jean, but we can split and break those out if we want to, or send them out well in advance of the meeting and then just take questions at the meeting, whichever.
I think, because I think what we need to do, we obviously need to prioritise the 5-year forward plan, because that definitely needs signing off. So what I think we'll do, I know I've been adding things all meeting. So what I propose, if it's okay with everyone, is that we, with the minutes, we'll do a draft forward plan of everything that we'd put through. And then as a board, we'll decide, we maybe have to prioritise for that June meeting, what we move about, I think is probably the best thing, because we might also have RMH LUF things coming forward as well, which again might need priority. So I think we should do that. Deb, did you want to say?
Yes, certainly the primary care strategy could come to the September meeting if the agenda's too full.
Yeah. I think having a list of everything that we propose to bring maybe in the next 6 months would be really useful, and would also be useful moving into the next administration. Yeah.
I have already drafted a draft work plan for next year. So what I'll do is I will update it and then send it out, and then we can play around with moving bits around.
I'm very lucky to have you being very efficient next to me. Right, is there any other, did anyone, what I would suggest is if any members want to add anything to that list, please do so. If you've got things in your head that need, just please put them on. Yeah, and then hopefully that will be great. And certainly, Mike, you and I will pick up outside around the HPV thing and everything as well. So, because that will need to go on at some point. Right, so any other urgent business? I don't think.
I haven't been notified of anything, Chair.
No, I just wanted to say a few words. Obviously, we are moving into election period. This might be my last meeting. So I actually wanted to thank partners. It's been a real privilege to chair this board this last year. I think we've done some incredible work when we think we've welcomed integrated care systems, place, that beloved strategy that we seem to be working on day and night for months on end. We saw through, and I think as a partnership, we really have come together and are working really well together. So I want to thank all colleagues sitting around the table for that. That's fantastic. I'd also really like to thank members of our community for their engagement and their commitment to the board, because they have always engaged with us, and actually that's a really positive thing. And finally, I want to say special thanks to my left hand over here, who I think members of the public and other members of the board may not realise just how much work she puts in around the board. So I certainly couldn't do it without her and without my prompt sheets and everything. So a huge thanks to Jane that keep the cogs working. Deb.
Thank you, Chair, and I'd echo the thanks to Jane and in fact all of the officers on the board. But and I think I'm hoping I'm saying this unnecessarily, but I think certainly on behalf of colleagues, I'd like to thank you for your leadership of this Health and Wellbeing Board. I mean, we've covered an enormous amount of work, and what's more, I think the partnerships that we've built across the last 12 months have been really important, and they've allowed us to have not only frank conversations about some difficult issues, but to do some joint work and gain some really good agreements going forward. So thank you, and let it not be the last.
Thank you very much, Deb. Right, so it leads me to say the date of our next meeting is proposed to be Tuesday, the 27th of June. It will be in the council chamber because it will be decision making, I'm afraid. It will be confirmed at annual council. Is that date of the 15th of May correct? I thought it got moved to the 22nd.
It has been moved.
Yeah, so we will, if you could pencil that the 27th of June into diaries, please. We will confirm after annual council on the 22nd of May. So I declare the meeting closed at 4:33, which is amazing, really, considering how far out I was at one point. Thank you very much indeed.
Thanks all.